Hello, this is Dr. Ayub. Today, I will lecture on the continuation of the upper extremity arterial supply that I mentioned before that there are some clinical pathophysiological condition that arise in connection with the upper extremity arterial supply, and those conditions, as I mentioned before, upper extremity arterial supply and its clinical pathophysiology in the following condition. Number one, subclavian still syndrome. Number two, Raynaud's syndrome. And number three, thoracic outlet syndrome. Okay, so these are the couple of things we like to discuss. And subclavian still syndrome, first of all I like to give you the idea that subclavian arterial disease, but the stealing is found in the vertebral artery. So if we draw the diagram again from the aortic arch, okay, so this is aortic arch, this is brachiocephalic trunk, this is right common carotid artery, this is left common carotid artery, and this is left subclavian artery, this is right subclavian artery, I'm just going to show you that how the blood is stilled and by the vertebral artery. So subclavian artery, the first branch is the vertebral artery. Okay, this vertebral artery, as we discussed before, that vertebral artery on right and left side, they joins together and form the basilar artery. So from both sides the vertebral artery arise and they go okay, they join together and they take participation in the circle of Willis. And vertebro-basilar system, they constitute the posterior 1/3 of the brain supply. Okay, so these are the vertebral artery VA and this is basilar artery BA. Okay, so our discussion is subclavian still syndrome. Most of the time in this condition that there is obstruction or occlusion, either partially or completely, congenitally. There is an occlusion or obstruction of the subclavian artery proximal to the vertebral artery. That means if there is an obstruction is over here or occlusion is over here or occlusion is over here on the right side, then what happened? The extremity, the upper extremity, right or left, doesn't matter, but the subclavian still syndrome, so far I know it is more common on the left side. And if there is an occlusion, do you think the upper extremity will be collapsed, will be dead? But why it is not getting dead? Still it is workable. How it is possible? Who is supplying the blood to the upper extremity? Subclavian, right? But subclavian is obstructed over here, occluded over here. But how? Understand that concept. If no blood is coming to the subclavian artery from the brachiocephalic trunk, so most of the blood, say 100% blood from the brachiocephalic trunk is going this to the right common carotid artery. The same thing here. No, from the left side it's not like the brachiocephalic trunk. Think about on the right side, if there is occlusion over here, so then what's going to happen? All the blood from the brachiocephalic trunk will go to the right common carotid artery. But what happened on the left side, if the subclavian artery is occluded over here, so then most of the blood will go through the left common carotid artery. And this common carotid artery has the external carotid artery and external and internal carotid artery. And internal carotid artery is responsible for anterior 2/3 of the brain blood supply. Okay, so now through the circle of Willis. And in this situation, look at here. The vertebral artery forms the basilar artery forms the posterior cerebral artery. Posterior cerebral artery is a component of the circle of Willis. And if the vertebral artery is not getting blood from the subclavian artery, so then circle of Willis will be deficient, right? With the blood? Yes, it is. But this vertebral artery, instead of supplying blood to the circle of Willis, it will steal blood from the circle of Willis and will have the reverse flow, will have the retrograde flow. Okay, so this is normal. Normal flow should go this way. This is normal. But now, while it is stealing the blood, that blood is coming back, or retrograde flow or reverse flow into the subclavian. Okay, so this is reverse flow. Reverse flow. That blood is coming to the subclavian. Question: why that blood is coming to the subclavian? And you know that flow always goes from higher pressure to lower pressure. As occlusion is over here, this part of the subclavian, has no blood. No blood means less pressure, no pressure. So here the higher pressure, here the lower pressure. Automatically, you cannot control. The flow will be from higher pressure to lower pressure. Okay? It is the law. So when the blood is coming reverse, then blood will go into the subclavian artery. And this subclavian artery will have blood, and that blood will go from subclavian to the axillary artery, and from the axillary artery to the brachial artery, and it is split into two. Radial and ulnar artery. So this would be axillary artery, this would be brachial artery, and this would be radial artery, and this is ulnar artery, and they will make the palmar arch and metacarpal branch and the digital branch, and this hand will be fine. Okay? But now get the concept. How much blood the vertebral artery will steal for the subclavian? I'm going to say, if not 100%, maybe 80% blood. That 80% blood is not 100%, not enough, but it is adequate to maintain the blood pressure, to maintain the nutrition to these muscles and tissues of the extremity. Muscles and tissues of the extremity, either left side or the right side. Now, if it is on the left side occlusion or in the right side occlusion, do you think that brachial pressure will maintain the same as the non-affected side? I will say no. No, because 80% blood is coming, not 100%. So blood pressure will be low. How much low? Usually 10 to 15 millimeter of mercury differences is okay. But if it is 20 difference between the affected and non-affected side, so then it is noticeable that it is 20 and above millimeter of mercury pressure difference. So which side is difference? Okay, get the Doppler on that side, get the volume on that side, arterial volume will be low. Then you will see the muscle type, muscle strength will be low. Okay, patient will feel little weakness on that side. Then do the Doppler, then you will see the subclavian artery proximal to the vertebral artery is occluded. What else you see? You will see the vertebral artery is returning the blood to the subclavian. That is called reverse flow. We call it subclavian stealing through vertebral. Subclavian artery is getting blood through the vertebral artery, and we call it subclavian steal syndrome. And the reverse flow will be seen in the vertebral artery. And vertebral artery Doppler we do in carotid protocol. We need to evaluate the vertebral artery along with the common carotid artery, ECA and ICA. Okay, so vertebral artery will show the reverse flow. Then you will notice what happened is a reverse flow. Then when you compare with the color flow, then you will see the common carotid is going red, but the vertebral artery is coming backward with the blue. So in that way you will understand there is a problem in the subclavian artery, that is congenitally patient may have complete occlusion or partial obstruction. If there is a partial obstruction and if there is a non-flow limiting obstruction, patient will not have any symptoms. Patient will be asymptomatic. Okay, but it can happen. So this is subclavian steal syndrome. In subclavian steal syndrome, what we're going to get? We'll get the affected extremity weakness. Pulse volume will be low. Blood pressure will be lower. Difference between the non-affected and affected is 20 or greater millimeter of mercury. And then strength of the muscle will be less than muscle wasting, and that's all. And patient might feel more cold in the affected hand, extremity more cold. Okay, and sonographically by Doppler study you will see occlusion of the subclavian artery, and you will see the reverse flow through the vertebral artery. Normal vertebral artery Doppler okay, this is normal vertebral. So peak systolic velocity is 60 centimeter per second. In diastolic, say 20 centimeter per second. Okay, so this is forward flow. And in subclavian steal syndrome, you will say it is reverse. This is baseline, and it is reverse flow. So this is a condition in which the blood is moving backwards. Okay, make sure you check. It is not error. It is not an error. It is the reality. It has been happening. Okay, so now if the vertebral artery is still the blood from the circle of Willis, initially the vertebral artery will steal blood from the basilar artery. Then basilar artery will say, hey, opposite side vertebral artery, hey, I need more blood, give me more blood, because I am getting less pressure, because my blood, somebody is stealing my blood. Then basilar artery will say, hey, yes, posterior cerebral artery, I need more blood, my pressure is low. That posterior cerebral artery will talk to the posterior communicating artery. Hey, posterior communicating artery, can you please bring more blood from the anterior 2/3 of the cerebral circulations? Okay, so there will be hemodynamically a flow, increased flow movement. Okay, so that is subclavian still syndrome. So now I will go over the Raynaud's syndrome. Raynaud's syndrome. And give me 1 second. Raynaud's is a name of a person. Raynaud's is a name of a person, and he found something, and that is very important, because clinically we found those cases on and off, and it is more common. Okay, it is more common. Raynaud's, my spelling is mistake, Raynaud. That's what I was, because there are two Raynaud's. One is the Raynaud's number, I wrote down Raynaud's number, Raynouds, Naud apostrophe S, Raynaud's syndrome. Okay, so this Raynaud's syndrome is important because lot of person, or you can say lot of people, especially the female, they suffer from this condition, and there are clinically there are typical findings of Raynaud's syndrome. One is from the primary, another is from secondary. Okay, so Raynaud's syndrome is primary, classified into primary and the secondary. The primary is known as Raynaud's disease. Okay, so now if I give you the classifications, it will be a little easier for you. Raynaud's syndrome is classified into primary Raynaud's disease and secondary. And this secondary, we call it Raynaud's phenomenon. Then what is Raynaud's syndrome? Raynaud's syndrome is feeling of digital vasospasm, mostly in the upper extremity, but it can happen to the lower extremity too. Lot of people, you will see, they get vasospasm and they get lot of chilly coldness of the hand, and they always keep the gloves on and under the blanket or under the any dress or everything, they want to keep it like this. Why? Because I feel cold. Oh my God, I cannot expose my finger in the winter, or I cannot catch the ice, and I cannot stand in cold weather or cold the refrigerator. Oh, no, I can't. Why? Suddenly I see there is some change of color happening. Initially I see the paler, whitish, then bluish, and then red congestion. This change of color is happening on and off, on and off, on and off. And there is a mechanism. Why is this been happening? So patient will come to the doctor, and the doctor will examine, doctor will take the blood pressure, and doctor will say, okay, right now I am not getting anything. In primary Raynaud's disease, where there is no organic cause, there is no structural cause to make this condition, that is spasm or coldness, cannot expose the finger to the air or in the cold or ice water, no. So then why is this been happening? Because of their emotion. The emotion psychologically they are. So this is due to the emotional then stress, you can say psychological, there is no organic or structural defect, there is no underlying disease, it's totally emotional. And women are suffering more. Okay? When they get the change in the hand, they found that the hand turned into